Greetings and welcome to the webinar. Thank you for joining us today. Before we get started, a couple of housekeeping notes. First, we will be doing a poll during the session, and you will see on your screen a question. If you'll please participate in the poll, we would appreciate it. Also, if you would like to ask a question to be answered after the presentation, you can click to the right of your screen on the dialog box in the area that says questions. I'm Adrienne White of Innovaccer. Welcome to the Innovaccer webinar series, The Grand Transformation of Primary Care. This is the first of 4 webinars in our series, and we're so excited to be bringing these intimate discussions hosted by 2 nationally known pioneers in the medical home movement. First, the doctor affectionately known as the godfather of the patient-centered medical home, Dr. Paul Grundy. Dr. Grundy was the founding president of the Patient-Centered Primary Care Collaborative, a primary care advocacy group in DC. He is currently serving as the Director of Global Healthcare Transformation at Health Teamworks and as the Distinguished Healthcare Expert here at Innovaccer. Dr. Grundy is joined by our Chief Medical Officer, Dr. David Nace. Dr. Nace has a long distinguished career holding various executive roles in healthcare IT companies and previously served as the chair of the board of directors at the Patient-Centered Primary Care Collaborative. Dr. Nace, I'll hand it over to you.
Thanks, Adrienne, and I appreciate the kind introduction and very excited to welcome all of the attendees to this very important webinar series about the importance of revitalized primary care to our healthcare system. So if we go to the next slide. As we all know, the big driver that all stakeholders in healthcare are concerned about is the continuing cost of healthcare in the United States. Over the past 30 years, the gap between what we spend here in the US versus other developed countries continues to widen. And we now understand the drivers behind that: chronic disease, uncoordinated care, high cost, high unit costs. And we know we have to find a solution to this because these costs are unsustainable. Next slide. So as I pointed out, we have this recognition now of the role of chronic disease. And one of the things that we've had in this country is the knowledge that the baby boom generation, the one that came out of World War II and the Korean War, is now turning 65. They're now getting older. So we have an aging nation. In fact, if you look at the data, the percentage, for the first time, the percentage of older adults are going to outnumber children in literally 15 years. We've never been in this situation before. And another huge driver is, how do we take care of our aging population, and how do we deal with the tremendous number of chronic diseases that are impacting the landscape? Next slide. And that brings us to this critical time. We need to really leverage what we know about the role of primary care in managing chronic conditions, the role and the need for coordination of care in our environment, and the need to bring specialty costs, high unit costs such as hospitals and skilled nursing facilities down, and how to really engage the community and engage both physicians and patients in terms of better taking care of their chronic conditions and better working in their community. We need to get our costs down. We need to improve the outcomes of these care. And if you look at the data that we see here, 12% of US adults currently have 5 or more chronic conditions, and 60%, the majority of Americans, have at least one chronic condition. We have to get our arms around it. And what we've learned over the past 20 years is that primary care is the solution, and it must be the chassis for healthcare transformation. So why is that? So for most of us, primary care is the first touch point, the place that we go, the place that we reach out for help. And the reason for that is there's a much deeper patient connection. We know our primary care physician. They know us. They sit in our community. They understand the world we live in. They understand the community services that are available. They understand our families. They're with us through the period of time that our conditions start to evolve, and they're far more affordable than going to specialists. They're far more affordable than going in and out of the hospital, traveling to other care providers, and they're far more accessible. They know their community, and they know their patients, and they know how to build their practice in order to build that access. And this all comes down to the fact that for primary care, they're the trusted healer for the patient. They're the folks that the patient can call, they know them, and if they have the information, they can really manage the care in the best way. So with that, I'd like to turn it over to the next slide and show the evidence for this. So at the Patient-Centered Primary Collaborative, where Dr. Grundy was the founder and I was pulled in and helped with Dr. Grundy in terms of driving this, we did some early pilots in primary care over 10 years ago and show that if we revitalize primary care into this model we know as the patient-centered medical home, we can have a tremendous effect on the cost and quality of healthcare. Look at the data here. I mean, we see a drop in hospital days, a drop in ER use, increased use of medication, more adherence to medication, reduced use of specialists, outpatient specialty care down, all costs dropping, and an overall improvement in outcomes. And what we've seen over the years since this study was published is the PCPCC, the Primary Care Collaborative in DC, has published every 2 years another edition of how these results are continuing to improve as these practices mature in this model of the patient-centered medical home. So I'd like to turn it over to Dr. Grundy, introduce him, and have him walk through the principles of the patient-centered medical home, or primary care 2.0, because these are the drivers of a new version of primary care that can really bring our costs down and improve quality in America.
Thank you very much, David. Dr. Nace, and next slide, please. So about 13 or 14 years ago, I was the person at IBM working on our benefits on our HR department at IBM as a physician, and my big boss almost died of a drug-drug interaction. I mean, like any self-respecting senior leader of a company, he had a separate specialist for every organ system. And, you know, so there was really no coordination of care. And that sort of event occurs every 3 minutes in the United States. So I was brought in and given a different task, the task of delivering transformation, having spent quite a bit of time in health policy in the US government, away from what we were buying to something of value. We did a lot of research at that time, and we wrote a paper called Why Employers Need Better Primary Care. The head of our HR testified before Ways and Means, and we reached out to the leaders in primary care, and we looked globally at what worked of value. And what we discovered was that if somebody had a primary care physician as their patient as their healer of record, and that was their normal source of care, that the evidence published demonstrated that it costs significantly less money and much better outcomes. So we began reaching out to the experts in the community, Barbara Starfield, Dan Duffy, some of the real leaders who've been working on this, and we asked for a change of covenant. We said we no longer want to buy an episode of care. We want to move towards managing a population proactively. We know we can get a surgeon to do an amputation, but we can't get the kind of care that prevents the amputation from being needed. That's going to require a whole different mechanism. So we sat down with the leaders and we articulated that change of covenant. You know, moving from an episode of care to the patients in your population are who you manage proactively. It's determined by a plan. It's standardized. We measure the quality. Next slide, please. We're prepared as a team of professionals. We track what's happening, and it's a multidisciplinary team. We took this to the House of Primary Care. We took it to the the American Academy of Family Physicians, to the American College of Physicians, to the orthopedic community, to the pediatricians. And we said, this is what we want to change to. This is what we want to buy. And Doug Henley, who was then the head of the American Academy, and still is the head of the American Academy of Family Physicians, looked across the table at me and he said, bless your heart. And now I know that means two things in the South. But, you know, this is exactly what we think we should do. In fact, these are the concepts that we articulated in what we defined as the future of family medicine. And we're so delighted that corporate America, and by this time we had 47 of the Fortune 100 agreeing to this change of concept principle. So that's kind of the beginning of the PCCCs and how we started that. But it was really about buying something different, buying something better that's going to require technology, information. So we're going to have you look at this poll and begin to answer this question. Adrian?
Yes. If you please select the answer that you think reflects what is the most important role that technology can play in providing and supporting better primary care in your practice or in your organization. Please select one of the following answers. We'll give you a moment to read them. Okay, thank you.
Wow, look at these results. Very interesting. So, Dr. Grundy, I'm really interested in your thoughts about here. Most people here are saying that, you know, if they look at their pain points and where technology can help, providing the most complete data and actionable insights at the point of care is the most important thing. And that's so interesting because that's what we're here to talk about today. And that's
exactly right. I mean, and thank goodness we're moving into the age of intelligence and out of the digital age, because that's kind of failed us, David. I mean, we really need much more robust access to information, you know, in a proactive way to help the docs, because we kind of turn them into scribes. So this is exciting to see that there's such agreement on this.
I think that's right. And the second most important thing we see here is the effective, continuous, and personalized engagement with the patient. Like, as a physician, as a practice, as a team, how do we engage the patient? How do we get them engaged in their own care? How do we get them engaged in the community? And what's really is exciting is that that's going to be the second piece of our webinar, which we'll go into in a second. And then look at these other things, like how can we achieve automation, right? How can we reduce those tasks in a practice that really don't add value, that people don't need to do themselves, that now we know machines can do, right? That computers can do, the web can do, and we can automate these tasks and allow people to work at the top of their practice, the top of their license. What really excites me about that one, Paul, is the fact that as a physician, I could relieve myself from many of these EMR recording, data recording, scheduling issues, and just focus on taking care of patients and working with my team. So anyway, really exciting results to hear what people are interested in. Dr. Grundy, you've walked around the country, you've talked to so many practices, you've been around the world, seeing so many people struggling with primary care, trying to figure out how to move to this model. Can you tell us a little bit about the current challenges that you've seen out there in the communities, both here and around the world, in terms of their challenges getting to this new model?
Thank you, David. I think we're trying to get to that slide, if we could bring it up. What I see is, as I literally travel the world and look at transformation, and again, we're going to be getting into this, is the asymmetry of information. You know, it's kind of early, it's kind of primitive at this stage. And so again, thank goodness that we're moving into the age of intelligence. And effective communication challenges. I mean, I hear over and over again, why can't I do to my patients what I can do on my iPhone when I do a Google map? The structural challenges of how do I structure a team to be more efficient? how do I better use my MAs? How do I go from half of my time working with my computer to really spending my time in difficult diagnostic dilemmas and relationships? Payment challenges. There's only one way to herd a cat, and that's to move the food. How do I align? How does the payment of the healthcare plans and the federal government and other payers align with what is expected of this new model of care? And then the regulatory changes and the burdens that are involved in that, I think are some of the really important current challenges that we're beginning to confront and face. Next slide. So empowering providers at the point of care. It's so exciting that we're beginning to see some technology come along that's going to proactively go out and pull in what you need and make it available to you without you asking for it. Again, in the same way that Google Map works and other things. Transforming provider-patient relationships. I mean, really engaging patients with technology. I've had a chance to spend the last 15 years doing a lot of work with the Danes and a simple reminder on your cell phone by a chirp that you need to take your medicine increases adherence and compliance by 12% and reduces hospitalization by over 30% for asthmatics. This conversion into team-based care, the human engineering of moving from I do everything as the provider to I have a team of folks that work at the top of their license, and I do the two things I need to do, which is sorting out difficult diagnostic dilemmas and relationships. Increased participation in the value-based model. So increasingly, all over the world, and certainly the United States, with MACRA and other payment changes, the demand of the buyers are to really begin to move from an episode of care to value and operation transformation. Next slide.
So with that, Dr. Grundy, as I've alluded to, this is going to be the first of our webinar series. We're going to have another 3, and this focus will be on empowering physicians at the point of care, just as we heard from the survey that people want to hear. That's the number 1 point. And then coming up, we'll look at how we can do that to develop longer lasting relationships with patients by engaging the patient with technology. And then later on in the fall, we'll talk about developing a team-based model and how do you leverage technology to support a team-based model, and then finally end up with really how to modernize and automate practices, the way the number 3. So the number 3 that we saw in the poll. So what's really exciting, Paul, is here is over the next few months, we're going to walk through all the things people have asked through. And at this point, I just want to turn it over to you and talk about the different ways that we can empower physicians at the point of care, just like people asked for. So with that, the next slide.
So again, we're going to go through these point by point, but what we discovered when we began looking at a foundation of care delivery was a survey we did with our employees. And what we found was that the most trusted person in their life was their family. The second most trusted was their healer. And again, when there's a longitudinal relationship between a healer and a patient, magic begins to really happen. The ability to have holistic records, the ability to get at the information we have, that's an incredible point of frustration. Access to real-time information that deals with gaps in care so that you really understand what's going on. Insight into the specifics of patient-level social information. Again, we'll have a slide on that. Opioids are a big concern, and we'll talk about that. Care management automation. If we could automate this, it'd make it so much easier. And then actionable analytics. Next slide. So as I traveled around the world, I was on a Korean airline flight once, and the hostess asked me what I wanted to drink, and I told him, and 10 years later, I was on another Korean airline flight, and they asked me if I still drank the same thing. That's data, that's information. I was at a practice in Iowa, and the conversation was with an 84-year-old nun, and the conversation started out, how is your didgeridoo lessons going? And the patient described her didgeridoo lessons. The doctor then said, you're going to go with my care manager who's going to organize your plan for your diabetes. and the beautiful plan was organized. I asked the nun, you know, what do you think? Well, I love my doctor. And the MA comes back and writes in the record the cat Millie, because that's what the doctor was talking about that day. So I said to the doc, what was that all about? She said, I spent a minute in blessing the relationship with information, real information about the patient, because there's no difficult diagnostic dilemma. And by the way, you know, I have a scribe that does the scribing for me, because I no longer want to spend half of my time with my face in the computer. And this is a little illustration of another practice that I visited, wasn't using a scribe, below, which is a 7-year-old drawing a picture of her interaction with her primary care physician, who's sitting at the table with his back of the head to the patient, and then the family there working on the computer. I mean, it's incredibly frustrating that so much time is absorbed in that. Next slide. So access to holistic patient records in the real time is going to be immensely important. And again, you know, data is going to do for the doctor's minds what imaging and x-rays done for our vision. It's going to make it clearer what's happening. You know, at the point of care, you know, in this new world, proactively, you really will begin to have the information you need to have, and it'll just be so much easier for you to do your work. Next slide. So in a couple of places, we really begin to look at how we can also go beyond just the information around sick care to the information around your social determinants of health and how to impact that. There was a great study that was done just a few months ago and published in, I think, JAMA, and it showed that 72%, as I recall, of folks who end up being hospitalized for acute hypoglycemic event with diabetes type 2 are in the last 4 days of their pay period. I mean, literally, they've just run out of food, right? I mean, they have a choice between rent and food. And so that's a huge issue. I spent some time on the island of Jersey, where they've repurposed the postman, whose mail has gone down by about 50% in volume. And they stop and they call and check on the frail elderly. They stop and they call and check on folks discharged from the hospital. I mean, it's just made huge impact. So in that particular community, what we've seen is that we've gone from an average of 11 readmissions in 30 days for congestive heart failure down to 1, because there's somebody who's engaged around other things and the social determinants of health and following up and following through. You know, and they put that information on a little iPad and can communicate that information into social services as well as healthcare services. In one of my routes around the island, one of the patients was a bit dizzy, and she was in her early 90s, and they were able to notify social services to get some help. And another patient made it clear non-verbally that she was in trouble at home, and there was an issue with abuse in the family, and they were able to get a hold of the primary care doc, and the primary care doc, you know, got a hold of the patient and got them down for some lab tests and discovered what was going on and got them into a safe environment. But again, thinking about the tools to go beyond just sick care and coordinate across the community. Next slide.
Paul, before we move on, yes. I really, really want to emphasize this point. There's a lot of people attending today that really have questions about this. So, you know, we've all been used to a payment system that rewards us to see people in a fee-for-service, right? So you get paid for when someone comes to your office and sees you face-to-face for a recordable, codifiable CPT code that demonstrates the visit. And yet we now know, over the past 10 years, we've really learned this, that the vast majority of interventions that really help with these chronic conditions are not on the fee schedule, right? They're in the community, just as you described. So as a physician, like working in a practice, trying to build a patient-centered medical home, how do I think about that? How do I think? Give us some other examples of how I can work with the community, like what resources might be out of there, and how do I go about thinking about that?
So An example of this beginning to percolate out is in the state of Maryland. I don't know if anybody on the call is from there, but they put a cap on the hospitals. So all of a sudden it became in the interest of the hospital not to have admissions, right? So they began investing in community services to reduce admissions. In Vermont, the Blueprint for Health that Governor Douglas started, they actually invested 2 cents out of every sick care dollar and created the role of a community coordinator. And so my newly diagnosed diabetic is introduced to the diabetic hiking club, is introduced to the nutritionist in the grocery store, is introduced to their local pharmacist around medication management. And that's a community where we've actually seen, a 60% reduction in the complication of diabetes, 60% less blindness, 60%, but again, the payment change methodology is coming down with value away from an episode of care, is beginning to reward that in ways that are going to be important because once again, you can't, the only way to hurt a cat is to move the food. I mean, you're going to have to put the reward around where you want and drive change. Does that answer that question, David?
It does, and I think I would like the audience to know, there's a lot of communities that are starting to understand this, that they need to collaborate with their patient-centered medical homes, their primary care practices, to really work together to forge this. So we see things like YMCAs that are starting to develop diabetes prevention programs. We see, I think the example, Dr. Grundy gave is how can we leverage organizations like the Postal Service that visit the home every day? How can we work together with the schools to think about how to get both prevention and intervention coordinated with the practices? And think about, most importantly, how do we present social determinant vulnerability at the point of care for a physician when they're seeing a patient in their office? And we're going to get to that. We have a little video we're going to show you how this works toward the end. But I think just really want to thank you for this discussion, Paul, because this is a key thing that we need to tackle. Let's go to the next slide.
So one of the big issues that's now surfacing over the past few years, and by the way, we now have more deaths from opioids than we do from motor vehicle accidents, is the crisis of the opioid epidemic. And again, as I travel the country and talk to folks who are dealing with this issue, one of their big issues is how do we get the data? How do we know what our patients are doing when they're going to multiple events? And I know, David, that Innovaccer's done some really interesting work in Northern California around beginning to focus on this. Do you have some thoughts and suggestions of what you've learned?
Yeah, we have this opiate crisis, and we've seen this around the country. Many of the stakeholders are trying to get their arms around it. And so one of the questions that's come up is this same question that we brought up before, Paul, which is, how do you get the information at the point of care to the physician when they're about ready to do something and they're thinking about the patient? What's often said, in their workflow. So we've actually worked together very closely in California because California has passed a regulation that by October 1st, all physicians must query a database, the Cures database here in California, to see all the prescriptions, all the controlled substance prescriptions that have been written for that patient before they ever prescribe a medication that's control 1 or control 2 through 4. And so how do you do that? How do you get that into the workflow? Because we all know physicians won't go out of their workflow to a portal to check on other information. We've tried that. Payers have tried it. Practices have tried it. So we developed a really elegant solution, and we'll show you a version of that in a video in just a moment, where just as the physician is working on the patient or their team is in the record working in the EMR, and they're about ready to write a prescription or consider a prescription for a controlled substance, the data from the Cures database is presented to them, showing all the different prescriptions, the time, and who wrote them as they're about ready to do that. And it's in their workflow. They don't have to go out of it. They don't have to type in anything, go to a portal. And that's the kind of elegance that we need to see that technology can really help support. And we're really excited about it. And, it's funny, people get so anxious about these regulations because they have huge penalties and burden associated with them. Health systems often have gotten sued for these kind of violations of these regulations. And now we have a solution that's elegant that can really work in the workflow of the physician. I mean, these are the kind of ways technology can alleviate us and allow us to do what we need to do without having to go out of the way to do it.
So I was visiting a primary care practice in New Jersey that I think you support, Osler, and it was really interesting. I was sitting in the doctor's practice, and this was a patient that was on pain medication, and without asking, provided at the top of the screen was their opioid prescription history. It was just so clear and elegant. It was really interesting. I mean, I think it's that kind of ease of process that we need to do to really help the docs begin to address this complicated issue. Next slide.
Agreed.
So when I first moved to the Hudson Valley in California in my new job as the Director of Global Transformation for IBM, i.e. working with government and building the PCCCC as an organization to help drive change, we arrived, and my wife is a cat rescue person, and so we brought our cats in for their immunizations, and my cat was sent a notification that it needed its immunizations. People tell me with their problems, and my wife got notified that she needed a mammogram, and she said, I probably wouldn't have remembered to do that. It saved her life. I mean, it's as simple as that. It's beginning to think about proactive management of what happens. I think we're at a point where we can begin to look at, the 5 patients that are probably most needy today, and what's the one thing we can do for them, and automating that in a way that can really impact, has had huge input. David, I know that working with one of the practices in New Jersey, you've really increased and had some amazing results and tremendous savings. You want to talk about that a minute?
Yeah, I think it's another perfect example of where not only if we have it teed up just like the veterinarian would do in the immunization reminder box with the cards years ago, if we can make it easy for people. So in that case, you'd have to go to the card box, once a day and check the box. But what we need to do is get it into people's workflow. We need to make the computer smart so that it knows what patients you're going to see, and it can think ahead of time with all the information prior to them coming into a visit and present that information as soon as the physician and their team are thinking about the patient as they're seeing them. And what we've seen in that kind of where you can present it at the point of care, we've seen a tremendous drop in, as you see here, the results is 19% drop in preventative visits, 16% increase in quality care gaps closed, and 18% in losing revenue, because if the computer is helping you, if the system is helping you through your workflow, automating many of the tasks like what patient do I see next, what information do I need to know, what steps do I need to take as I'm working with the patient, then it really increases your revenue. And really, you don't lose revenue by having the discoordination of having to go other places and look things up in various systems. So having the computer and the system support you and your workflow and the patient and the team is what's key.
So this really helps even in a fee-for-service world by identifying gaps in cares automatically, with the machine learning, with artificial intelligence, with neural networking. The system can go through and find out, what's missing, who's not had their breast exams, who's not had their colon screening, automatically notify them in a really sophisticated way. I mean, it's fascinating to see what happens. Looking at patterns, it becomes clear that a woman with 3 or more kids is best approached on Tuesday evenings after 8. It becomes clear how people respond. Do they respond better by mail, by email, by voicemail? How many times do you remind them, and then how long do you wait to remind them again without giving them fatigue? I mean, that sort of thought process of really increasing access to getting at those gaps in care and identifying them not only saves huge amount of money, but it makes a huge difference. I was in a cab in Ireland a few months ago, and my cab driver described what happened to his wife. His wife was 47, had a stroke. She was a teacher. She's paralyzed on one side. She now no longer can speak, with 3 kids. And that was for the failure of identifying and treating your hypertension. I mean, it just can make a huge difference if we can begin to automate a process. My kids who are in their 30s have never seen a teller in a bank. They never will. They use their cell phone. So we have a vastly different means of communicating, and that's how the millennials want to be communicated. Next slide. So one of the early pilots we did in Tulsa, Oklahoma, was paying the specialists to answer the emails from the primary care providers, and then that payment began to make the process accountable because somebody was paid for it. So all of a sudden, we're actually tracking the referrals. And the interesting thing that happened as well is that the specialists were much happier because they were not weeding out 40% of their patients that they didn't need to see, that were in the wrong place at the wrong time. The companies were much happier because they weren't losing half a day's work for somebody taking their mother to a specialist. And the primary care docs were happier because they could have a complete record. By the way, the specialists didn't get paid until they actually got that information back to the primary care doc. So it began to create this loop with the technology to be able to do that. That's now spread to 7 other locations around the United States, and it's really exciting to see that we're beginning to get at and understand and have the technology to make information actionable around referrals and specialty care. Next slide. So tracking, following up, following through, we've just got to help you make that a whole lot easier than it is now. It's got to be a whole lot more accountable. And I think we're beginning to get that. David, you have an example of how that's worked now in a specific case of orthopedic surgery.
That's exactly right. So thanks for that. So as you can see here in this slide, as a primary care physician, I'm thinking about making a referral to a specialist. And today, I don't have what Paul just referred to earlier as X-ray, right? I don't really know how my specialists are performing in terms of quality, in terms of cost, and actually in terms of how patients feel about their interactions with them, patient satisfaction with them. What I do know is my experience in the past from my own memory of who I like and who maybe gets back to me, or who I think is the best because my peers tell me that. So if I can present information, like we all pick a restaurant by using Yelp or another version of Yelp, where we can go to a site very quickly. I'm thinking of going out to dinner and look up, and you see 1 to 4 stars rated on quality, and we trust that. We see dollar signs 1, 2, 3, or 4. We know, well, we want to go to an inexpensive restaurant tonight or an expensive one. And we see information of how people have been satisfied with various aspects of that service. And that helps us make a very quick decision with a visual that's elegant, right? And so we feel comfortable, we feel confident, and at the point that we need to make that decision, it's presented to us. So can we do the same thing around, just like we talked about a moment ago, Paul, around prescribing a narcotic? Can we get that information about who else does that right away? Can we do that around referrals, right? Can we add that kind of information as soon as we want to make a referral? And we may suddenly see that, oh my gosh, the person I usually refer to is far more expensive than some other people in the area, and maybe even has lower quality. Why would that be? And we need to make sure that information is trusted, but more importantly, what this information provides isn't necessarily a decision, because it's just information like an X-ray for a radiologist or a physician looking at an X-ray. It engenders a question that needs to be asked. So I always call this, Paul, I call it the golf course conversation. So the orthopedic surgeon that I always refer people to, and I've never known what the cost or quality is, when I'm out on the golf course with them the following Saturday, I can start to ask the question, so help me understand why you're 3-fold the cost of another orthopedic surgeon, for example, for a knee arthroplasty. So there's data we have here about what we see and information that we see today in our markets about the variation of cost for the same procedure done in the same way for the same type of patient. It can tremendously vary from, say, $5,000 to almost $100,000 for no particular reason other than the cost is different. Maybe they're using a different appliance, maybe they're using a different procedure, but generally it's just because their cost is different for no particular reason. So I think it's a perfect example of where we can bring that kind of information at the point of care, so that otherwise would not be known in real time to the physician when they're making a decision, can suddenly open their eyes. And Paul, as you say, the x-ray, they refer to, maybe it's a hospital that they traditionally admit to. But Paul, just make a comment, because you've been around the world and talked to these practices. Tell us more about this experience of providing information, how it's like in the x-ray to the primary care physician.
So, to begin to pull the information together so you have a whole picture, and again, that was the number one thing on the little exercise we did. It's just incredible what value that can bring. I mean, in the Danish experience that I've had, when you push your pill through the aluminum foil, the system knows you've dispensed the pill. There's just this feedback loop of information that you can get at. And I'm just so excited to understand that we're now beginning to get the technology to pull that together. And right at the top of the screen, without you asking for it, you now know what somebody else is doing to your patient and what you might need to do about that. It's just gonna revolutionize care. I mean, I remember, if we were discussing not healthcare, but delivering of goods 100 years ago, should we reshoe the horse Daisy or should we buy this newfangled thing without a horse? Wasn't so clear back then. I mean, that's kind of where we were when we started with the EMR, and we're now beginning to advance beyond that. And a lot of this is going to be a lot easier to be able to get at with artificial intelligence, with machine learning, with neural networking. So I'm really excited about that, really making it clear on the screen.
That makes a lot of sense. Let's go to the next slide and really try to pull all this together. Paul, if you can just sort of wrap us up into, primary care 2.0 in action and what the future holds for us. And then we have a couple questions I'd like to get into from the audience.
So when you look at this slide and you think about where in the system is there accountability? And that was what we began thinking about all those years ago. I mean, if you're gonna have data, there's an expectation in any industry that somebody is going to be accountable for that data. We used to build cathedrals out of somebody's head as a master builder, and we still practice medicine that way. But that's not a very good data storage device. Now that we're going to have information, there's an expectation that somebody's going to be accountable for that. And we contend that person needs to have a healing relationship with trust. It needs to be their primary care clinician that is that system integrator, the place in the delivery system that's actually accountable for organizing data. So proactively managing a population, being aware of what's happening at the hospital level with the specialists, with public health information, and then having the tools to actually begin to look at the community support around that patient, and work a lot in the English context where they have much better social services. But again, going back to that Vermont model of an actual system where there is a community coordinator that pulls together all the social services once a month and the data around that patient to actually support the patient. I spent a week in St. Johnsbury, Vermont, where they do this. Boy, the doctors just love it because they know that prescribing an anti-diabetic medication isn't going to do much if somebody lives under a bridge and doesn't have a home or hasn't got their depression treated. So pulling that together is going to be immensely important. And that's what I think of primary care 2.0. It's really primary care as a system integrator, moving away from an episode of care to proactively managing a population with data. And for the first time, we're going to have data. And then being accountable for the overall cost of care, for the overall provision of care across an ecosystem that I refer to as the medical neighborhood when we talk about specialists in hospital, or the community care when we talk about social services.
So I think that's exactly right. And, you know, we've made tremendous strides over the past 10 years, getting this concept of the patient-centered medical home in place. And many of the measures and things that people have been checking the box on are fairly process-oriented, but what it has allowed is for practices to start to think about things like access to care, expanding that, of working together as a team, and then maybe bringing care coordinators into the picture to help them think about things the doctor doesn't need to do, but more importantly, to coordinate all of the caregivers around the patient. But what we need is data to be liquid. And we need data to be liquid when it's needed in real time and presented to support with insights the actions that need to be taken and can be taken to achieve all these things. So let me ask you a question. We have questions from the audience, they're really good ones. First one is, will CMS empower primary care physicians and really allow them to evolve this model? Or there's a concern that the current administration is changing the initial version by unbundling that and empowering specialists in their hospitals. What's your view of the direction things are heading, and where do you think things will go?
So I've had the privilege of interacting with our current Secretary of Health and Human Services, and I think I would also look at the webinar that just happened yesterday at the PCCCC. I mean, I just don't think there's any turning back. Because the drivers that are driving this are universal. Unsustainable costs. For the first time, we're going to have data. We have to do something about it. And with our cell phones and with the communication, we have a vast different way of communicating. You know, there's going to be occasions and times when there's going to be, you know, 3 steps forward and 1 backwards, and maybe we're a bit in that mode now. But I think the overall trend is going to be driving in a positive direction towards proactively managing a population and being paid to do that, and stop being paid already for doing episodes of care only.
That makes a lot of sense, and that provides a lot of hope for all of us, I think, and I agree with you completely. I think the momentum will continue, and that unsustainable cost will give the politicians the reason to move in that direction. So that we have one other question here that we have time for, which is, with the changing emphasis to go back to primary care as a care coordination center, how can we ensure that there's enough primary care providers to provide this care, given the current shortage in primary care physicians?
Again, David, I'm very optimistic about that as well, because frankly speaking, I don't know if we need more primary care docs. I think we probably do, but we sure need to make them more effective in what they do. It breaks my heart to see what happens in a primary care practice. They only spend 1/3 of their time doing what they should do, which is difficult diagnostic dilemmas and relationship. In team-based care, and I've seen that roll out, we're now in year 14 at UCSF and at the University of Utah, where I'm on the faculty. And you really see happier docs, but there are 2.2 MAs for every doc. The MAs do the MAs do the scribing. It's a system of flow that just makes the doctor's day much busier, and they go home on time. I think the other thing that gives me great hope is that the last time we began to give some optimism to primary care in the HMO movement, there was a huge uptick in primary care docs applying, and that's happening now. This is the 11th year in a row where there has been an increase in the percent of medical school graduates going into primary care, with many new osteopathic colleges and allopathic colleges that have a focus on primary care. So I'm optimistic that in the long run, we're going to have, you know, an increase in supply. But again, in the Danish context, and in, you know, the primary care docs are the highest paid specialists there. So we also need to continue to work really hard, and that's what the PCCCC is working on, to advocate for better payment. I just testified in Oregon and in Colorado, and we now have in Rhode Island. This is the 8th year where we've had a 1% increase in payment to primary care by law. Colorado is positive. Oregon is moving in that direction. So we're beginning to see states understand that they need to figure out through their insurance commissioners and other mechanism how to pay primary care more for what they do, because relatively speaking, they're undervalued, but as they become increasingly more important and being seen as a system integrators, I think they're going to be more valued in the system. The other thing is that this is the 5th year in a row where thoracic surgeons haven't found jobs after their training, and the highest demand specialty now is family medicine.
Yep, this is really hopeful, and I still remember back in my early days of training in medical school when I came out, anesthesiologists were in great demand, and 10 years later they realized that nurse anesthetists were the key to cost, and suddenly anesthesiologists' salaries started plummeting. So it's very interesting about this demand issue around physicians, and it's so helpful to hear that the big demand is coming for primary care. The last question we have time for is interesting, very interesting. It relates to everything we're trying to do, certainly at Innovaccer, but in this talk. Here it is. Why is PCMH the hub? Wouldn't it make more sense to have that move to an insurance company since they have all the financial information and the claims? Or wouldn't it make more sense to have a partnership between the primary care practice and the insurance company to ensure the information is brought together? So this is exactly what we're doing at Innovaccer. We're creating a data hub that creates data liquidity and puts all the data, the financial data, the claims data, the clinical data, the data from the community, the social determinant data, all in one data model to really inform physicians at the point of care, to inform patients, and we'll get to that in our next webinar, at the 24/7 point that they need it, when they need it, and to work with their primary care team to manage that information and really address care gaps. So we're looking forward to our second webinar, which you should expect an announcement about in September. And again, after this one, after we talk about engaging patients, we're going to move on in subsequent webinars to talking about how to develop a team-based model with an underlying chassis of a data hub. And then lastly, how to modernize practices, how to automate the many of the non-value added in a practice and create a win-win for not only providers, but payers and patients. Again, I can't emphasize enough that last question is, how do we bring everybody together and operate off the same information? That's what will make a difference in our costs. That's what will make a difference in our quality. And I just really want to thank everybody for coming today and hearing this very important webinar. I want to thank Dr. Grundy for your coming as well. And I'll just turn it over to you, Dr. Grundy, if you want to make a few final comments before we close.
So thank you very much, Dr. Nace. Going back to that last question, I grew up in West Africa, and I understood the power of the traditional healer. I think the reason why we want to have as the hub the healing, trusting relationship is because trust is so important. In the Danish context, the very first class you have when you go to medical school is how to develop and maintain a relationship of trust. When we did the disease management program study from the Medicare some years ago, the only 3 that really worked were the ones that were directly from primary care. I just think that it's that relationship of trust that's key to where you want to make accountability occur. But boy, they've got to collaborate, and there needs to be an understanding of the payer and the buyer of care as well. So thank you very much, David.
Yeah, no, and thanks everybody for coming, and this will close the webinar for today.